departments, dear colleagues. At the beginning, I'd like to introduce myself. I work in Samara Regional Clinical Hospital. Samara is a big industrial city with 1.5 million population in the central part of Russia. Specialization of our department are hip and knee replacement, and my first overseas cup was RM cup. It was like first love for me, especially as because in basis of this implant was the groundbreaking idea of Robert Mattis to develop an uncemented acetabular component with a modulus of elasticity adapted to physiological bone deformities. Uncemented RM acetabular component is a non-modular hemispherical device manufactured from ultra-high molecular weight polyethylene and coated with a thin layer of poor titanium particles. This coating promoted secondary osteointegrations but does not influence the elasticity as occurs with metal-backed acetabular components. Primary fixation is provided by two anchoring pegs on the weight-bearing parts, supplemented by screws inserted through the periphery. Recommended angle of inclination of this cup is 30 degrees. This angle provides good fixations and minimal loading of polyethylene surface. Typically, RM cup demonstrated good medium and long-term follow-up results in primary cases. For example, Eve and Bambelli reported about 99.8 survival rate after 4 years. Dragin et al. Reported in 2008 survival rate 98.8 after 8 years. Schwartz and al. In 2003 writes about 100 survival rate after 11 years. Ireland all in 2008 gives a 83% survival rate after 20 years follow-up. We use RM cup from 1996 and performed 56 implantations in more difficult cases in patients with poor acetabulum bone stock. In 38 cases we use poly cobalt chrome bearing, and in 580 cases poly alumina ceramic. In 48% of our patients, indications for hip replacement was hip dysplasia. In 28, arthritis with deep acetabular protrusion. In 16% post-traumatic defect, and in 7% cases cavitary acetabular defect in revision procedure. Hip dysplasia was a more common reason for RM cup implantation. As said McKinsey, acetabular reconstruction in congenital dysplasia is unresolved issue in total hip arthroplasty. And according to DeBorn, primary hip arthroplasty in congenital hip dysplasia is more difficult than a standard hip replacement. That's why revision rate achieved 11 and 20% after these primary procedures. Sir John Chanley formulated gold standard. Main point of this is medial acetabulum wall must be keeping. Johansson writes that cup need placed as medial as possible without violation of the cortical bone of the cotyloid notch. Many years the medial acetabulum wall was a sacred cow, but Dan, His and Lakatos proposed alternative technique, medial acetabulum protrusion. This method gives a good bony coverage and cup stability. In 257 patients with type 2 and 3 acetabular dysplasia was used medial protrusion techniques with obligatory bone grafting in medial acetabulum wall. Excellent and good medial term results were obtained. Only 2 RM cups were revised. I'd like to show you some clinical results for illustration. Case 1, type 2 of acetabular dysplasia, we used the horizontal cup position and protrusion techniques. Follow-up results after 8 years. Case 2, type 3 of acetabulum dysplasia, protrusion technique, and massive bone grafting were used. Follow-up results after 7 years. Case 3 against type 3, massive bone grafting and protrusion techniques. 3 years, 3 years follow-up. The RAM cup showed its versatility in the treatment of deep acetabulum protrusion. We prefer use the jumbo cup insertion of large implants with the support on the intact acetabulum rim. Additionally, we graft the medial wall with bone chips from the femoral head. The chips were firmly impacted into the floor. The same technique we use in revision of acetabular defect type 1 and 2 ABC according to Popovsky classification. After all, we can think that a RAM cup is extremely perfect, ideal cup for hip replacement. Unfortunately, this coin have another side, impossibility to change inlay and make a dry revision. It's especially important after 7 and 9 years. On this slide we can see increasing revision rate in reason of stem instability. Stem instability predominate over our reasons of revision on this stage. What we must do in this case, change the good fixed cup of leaf-walled cup in acetabulum. To change cup and destroy all our reconstruction? If you ask me, will I use this cup in the future so widely? Now I answer rather no than yes. Thank you for your attention.